We will start with a discussion about lower pulse stones. I would like to invite first presenter, Professor Shimon Meretyk. He talked about ESWL treatment of lower pulse caliceal stone.
Good morning. I'm supposed to talk about ESWL of lower caliceal stones. So, caliceal stones, most of them are asymptomatic. Some of them are post-procedures like PCNL, RIRS, or ESWL. And the first question is whether to treat them or not to treat. And the answer is not so simple, because if we look at the natural history of caliceal stones, there are about 16 studies, 1,921 patients, and there is a very wide range of rate of disease progression as defined by the risk of surgery, that is between 0 to 33%, risk of stone growth, that is between 4 to 60%, and risk of stone to become symptomatic between 6 to 48%. Only up to 1/3 of the patient will need intervention, surgical intervention during follow-up of 3 to 5 years. So, looking at the guidelines on urolithiasis of the European Association, we can say that active surveillance with annual follow-up of symptoms and stone status is an option, but only for very short period, 2 to 3 years. After this period, intervention should be considered, and also observation may cause higher risk of need for more invasive procedures. Grade of recommendation C. So, to treat or not to treat? The question is still unanswered, but there are definitive indications for treatment of caliceal stones, and those are stone growth, stones becoming symptomatic by obstruction, pain, or infection, stones greater than 15 millimeters, and patient preference. If there are no known contraindication of ESWL, like pregnancy, bleeding diathesis, active infection, obesity, and skeletal malformation, aneurysm near to the stone, obstruction distal to the stone, or uncontrolled hypertension, we have to start the pre-ESWL treatment planning, and we have to look at the stone factors and kidney factors. Looking at the stone factors, first of all, we have to look at the stone size. And we all well know that bigger stones means lower stone-free rate and higher retreatment risk. For stones up to 10 millimeters, the expected mean stone-free rate is around 80%. And for stones above 20 millimeters, the expected mean stone-free rate is around 54%. Therefore, stones in the renal pelvis, upper and middle calyces up to 2 centimeters will be treated by ESWL, and stone above 2 centimeters by endourology. Grade of recommendation B according to the guidelines. The next stone factor that we have to look at is the stone composition. We well know that there are some stones like calcium oxalate monohydrate, bruchite, and cystine stones that are relatively ESWL resistant. Also, we know that stones with density above 1,000 Housefield units are relatively ESWL resistant. And last, we look at the stone location. Pelvic and upper and middle caliceal stones are cleaning much better, and the expected stone-free rate is around 56 to 80%, while for lower caliceal stones, the expected stone-free rate will be much lower, around 60%. The next, following the stone factors, we have to look at the kidney factors. And regarding the kidney factors, we all well know that hydronephrosis and anatomical variants like horseshoe kidney may influence and contribute to lower stone-free rate. Also, lower pole anatomy, acute infundibulopelvic angle 70 to 90 degrees, a narrow infundibulum below 5 millimeters, and long infundibulum above 30 to 50 millimeters may contribute to low stone-free rate. We know that there is a problem with this concept of lower pole anatomy. There is a lot of controversy regarding lower pole anatomy. There are 7 studies with 571 patients, lower caliceal stones between 10 to 25 millimeters, and stone-free rate between 52 to 69%. And 4 of the studies are claiming that there is a correlation between narrow infundibulum and stone-free rate. 6 of the studies are claiming that there is a correlation between infundibular length and stone-free rate. And 5 of the studies are claiming that there is correlation between infundibular pelvic angle and stone-free rate. In the contrary to this, there are similar number of studies, 6 studies, with similar number of patients, 601 patients, similar lower caliceal stone size, 20 to 30 millimeters, and stone-free rate ranging from 21 to 96%. And all of those 6 studies are claiming that there is no correlation between the lower pole anatomy and stone-free rate. So at this point, we can summarize the last 2 tables saying that the influence of lower pole anatomy on stone-free rate is questionable. The influence is possible, but seems to be of minor clinical importance. Still, lower pole anatomy is recognized by the European guidelines as being a predictor of stone-free rate after ESWL. Also, we can say that the range of stone-free rate after ESWL of lower caliceal stones is very wide, from 37 to 96%, median 60%. Meta-analysis, additional study, meta-analysis of 2,927 patients, the stone-free rate is again around 60%. At this point, we have to ask ourselves 2 questions. First, is stone-free rate of 60% good enough to choose ESWL as the preferred and least invasive treatment of lower caliceal stones? And the answer should be definitely yes. The second question, is a more invasive treatment justified to achieve higher stone-free rate if the clinical insignificant residual fragments has questionable or no therapeutic consequences? And the answer should be no. We can optimize the ESWL outcomes by changing the treatment strategy, applying coupling gel generously to the shock head, level of evidence 4, using delayed voltage escalation, level of evidence 3, and slowing the treatment rate, level of evidence 1A, 1B. Also, we can improve the stone-free rate by using mechanical percussion inversion diuresis, level of evidence 1B, medical expulsive therapy, level of evidence 1A, and potassium citrate, level of evidence 1B. So to summarize, the treatment algorithm for lower caliceal stones as it was presented by the guidelines on urolithiasis, European guidelines on urolithiasis. Stones below 2 centimeters should be treated first choice endourology. Stones below 1 centimeter, first choice of treatment should be ESWL. In between, stones between 1 to 2 centimeters with favorable factors for ESWL should be treated by ESWL. If the factors are unfavorable, which means the composition of stone is hard or the lower pole anatomy, if you believe it is bad, you should go for endourology. Thank you.
Thank you very much. Any questions from audience? Thank you, Shimon. The next speaker is Dr. Duvdevani. Please, you invite to the stage.
Good morning, ladies and gentlemen. So this is not going to be a state-of-the-art lecture. The title of the lecture was Has the Last Word Been Said? So I'm going to show you what I think that it hasn't yet. So we are talking about lower caliceal stone and the option of PCNL treatment. We all know, and we have just heard, that the management of lower pole calculi is challenging, and we know that there are actually four options. One of them is observation, which we were supposed to hear by Marshall Stoller. The other three treatment options are ESWL, RIRS, or PCNL. There are several critical factors that make PCNL more favorable. If we really want a high stone free rate, depending on stone size or the internal anatomy of the lower calyx, if we are interested about cases regarding patient morbidity, cost, and hospital stay. And we all know the old lower pole study group from the early 2000 that compared the PCNL treatment to ESWL with lower caliceal stone, and the results were quite convincible. We have just heard from Professor Meretyk the EAU guidelines of 2013. There is already guidelines of current year which said that stones in the lower pole shockwave in the lower calyx is not favorable because the success rate is lower. A fragment will be kept in the lower calyx, and new stone can be created from the residual fragments. Again, there are unfavorable factors for ESWL, which are the type of stone. There are several resistant stones like calcium oxalate monohydrate, brucite, or cystine. We have just heard about the internal anatomy, and I think not many people can argue that the success rate or the probability of passing fragments from the right-handed lower calyx is different from the left one. So the EAU guidelines of this year suggest that lower pole stones should be treated by PCNL or RIRS, even for stone of 1.5 centimeter. What about PCNL? PCNL is very effective surgery, we all know that. However, do we really need that? So for a specific cases, the answer is yes. If there is a large stone volume, if there is a situation with hard stone that is not amenable for ESWL, if there is a distal obstruction to the stone, can be a UPJ obstruction or caliceal diverticulum or narrow infundibulum, we should choose percutaneous approach. In several conditions that can cause a difficult for patient lying in the operating room, like morbid obesity, orthopedic situation that cannot put the patient in lithotomy. If we want to be sure of the results, like pilots or Sturite stones, we would not like to have residual fragments in these cases. Other modality failures. RIRS is a very, very efficient and very good option, but we all know that there are certain situations that lower caliceal stone cannot be reached by retrograde fashion. There are several manuscripts that investigated the quality of life after PCNL, and one of them was currently published and found that the outcomes and the quality of life after PCNL was improved dramatically, both short and long-term quality of life. PCNL is a bomber, as I showed you, comparing to other options, comparing to other endourology option and comparing to shockwave lithotripsy. It has, although rare, but sometimes significant complication, like sepsis, bleeding, even though not so common, but sometimes there is significant bleeding that necessitates something very active and urgent. Bowel injury, I think Meretyk, it's yours. Bowel injury, pneumothorax, hydrothorax, AV malformation, etc. So is there a way to make the procedure, this approach, more gentle? We should improve the performance. So how can we do that? By improving the technique, the experience, and maybe a real-time accurate imaging modality like is being done in hybrid operating room can help with this approach. Another way to lower the complication rate maybe is due to miniaturization of endoscopes by mini-perc and even micro-perc. I don't know how can we go in such a 6-month-old baby with a caliceal stone or even a pelvic stone by a retrograde fashion. I really don't know yet the instrument that can go upwards through its ureter. Of course, riding with B52 over this target would destroy it. However, we can minimize the tract and do it mini-perc and complete the surgery with a stone-free status. So what is mini-perc? Mini-perc, the real classification is tract of less than 20 French. Many say that it reduces the chance of hemorrhagic complication, less pain, reduce hospital stay, and multiple tract can be done with a more safe fashion. In 2011, I'll show you in a minute, Mahesh Desai introduced a new possible option for PCNL, which is called the micro-perc. Micro-perc is being done by 16-gauge puncturing needle which is called the all-seeing needle. I'll show you pictures in a minute, with 200 micron laser fiber. It's being written that it reduced the cost of RIRS, but it is still, although 3 years already, an experimental technique. So the all-seeing needle is a 16 gauge with 3 channels. It has an irrigation channel, an optics, and a working channel in it. And you can see all the way into the calyx, directing to the calyx. Imagine this 6-month-old baby undergoing this surgery with this needle, just to the calyx that the stone is being there, seeing the way to the calyx and breaking it with laser. Correct, if we can come to this stone retrogradely with a ureteroscope, it is probably preferable. However, there are selective cases that we will not be able to do that. So this is how I see the future.
Thank you very much. Any questions from the floor? Yes, thank you.
Thank you for the talk. This is on. One of the most unpleasant parts of PCNL for patients is the nephrostomy afterwards. What is are you still leaving nephrostomies routinely, or have you gone to no nephrostomy for certain patients?
Yeah, I know very well the debate of tubeless PCNL. I know the pros and cons. I am still leaving a nephrostomy tube after the PCNL. I don't think that I have to tell you again what are the advantages that we all know. I think getting the patient really stone-free after surgery and getting to know what is inside the kidney, if he's bleeding, if he's obstructed or not, is very important. There are several patients that I faced with obstruction after surgery, and I'm doing flexible nephroscopy at the end of all surgeries, and I'm injecting contrast. I see contrast passing directly to the bladder, and I'm very happy. In this situation, nephrostomy tube helped me to repeat a clinical secondary PCNL without anesthesia and taking out the obstructing fragment. It was just there, and they went home without any tube and stone-free. Yeah, I know you would come.
Thanks, Moti, for the presentation. A comment and a question. The comment is, I believe that there is no more debate today about tubeless or standard PCNL. Tubeless is the way to go. And my question is, you just talked about mini-PERC or micro-PERC procedures. They are really less invasive than a standard, because your definition was that a mini-PERC is the operation that you use a tract less than 20 French. The difference between a 20 French tract and a 24 French is a diameter of 1.3 millimeter. Does it make the difference?
So I would answer both questions. There is a very important review article a month or 2 months ago that reviewed many centers worldwide, and only 2% of the centers are doing tubeless PCNL worldwide. So there is a debate, Mario, and I appreciate the tubeless fashion. I don't think it's wrong. I just feel, from my point of view, that it's better to do it with nephrostomy tube at the end. Well, I'm not God. I might be wrong, but this is how I'm doing. 1.4 millimeter is not much, but if you collect several such distances and you think again about this 6-month-old baby with 5 centimeter length of a kidney, I think any millimeter would make a difference.
Anyone questions? Any more questions? Sorry. Thank you, Moti.
Thank you.
I want to invite next speaker, Dr. Scott Hubosky from Thomas Jefferson University Hospital, Philadelphia, is going to speak about retrograde intrarenal surgery.
Thank you. Appreciate the opportunity. What I'd like to speak about is the use of ureteroscopy or retrograde intrarenal surgery for treatment of lower caliceal stones. So whenever there is level 1 evidence on a subject, it's worth mentioning, and this is a study that is not quite 10 years old, that was a prospective randomized trial demonstrating stone-free rates using either extracorporeal shock waves or ureteroscopy for lower pole stones 1 centimeter or less. And they defined their stone-free rate by a CT scan that was done 3 months after surgery. As you can see, the rates are different, and the absolute numbers are better for ureteroscopy at 50% versus 35% for ESWL, but these numbers were not statistically significant. However, what is important is that they studied patient-derived quality of life measurements, and they all favored shockwave lithotripsy, including the mean time that it takes for patients to get back to work. In addition, 90% of the patients who had shockwave lithotripsy said that they would do the procedure again if they needed to, whereas only about 63% of those who had ureteroscopy would do it again if needed. Keep in mind that 89% of those treated with ureteroscopy had a stent, and that clearly would add to their negative perception, as I think we would all agree. The conclusions of the study were that there weren't statistical differences between the two modalities with regard to stone-free rate, but ESWL was better for patient acceptance and shorter convalescence. But I would caution everybody that the limitations, especially with this study, is that it took 19 centers for them to accrue enough patients to do this study. That's 19 different urologists with 19 different potential ureteroscopic techniques. So that is clearly a limitation of this study. If we fast forward to today, what I normally consider the variables that are important for treating lower pole stones, well, first, it's not even listed here, is it in the patient's interest to do anything at all? The answer is sometimes no. But if the answer is yes, we need to do some sort of treatment, then we need to consider these variables. Stone size, the intrarenal anatomy, which was touched on previously on our first lecture, the patient characteristics and their surgical history and their stone composition. These all have to be taken into consideration. Broadly speaking, stone size will direct our approach, and I think most people in the audience would agree that if we had a lower caliceal stone that was greater than 2 centimeters, that PCNL is probably the way to go. I think most of us would agree with that, unless there was a clear contraindication to doing that in a particular patient. For stones between 1 to 2 centimeters, I think any of the 3 modalities would be viable depending on the particular situation. For stones less than 1 centimeter, personally, I would prefer to avoid PCNL's morbidity for stones this small, in which case ESWL would be what would be preferred if the anatomy is favorable, ureteroscopy for all others. In situations where you may do ureteroscopy for a ureteral stone, if there's a lower pole stone in the same side, we would just go ahead and treat that. If there were multiple stones and there happened to be a lower pole stone and the stones weren't too large, we would do ureteroscopy. For larger stones, we may consider PCNL. This was already touched upon, but I personally think that this does make a difference. This is a paper that was actually out of India not quite 15 years ago, but they looked at stone-free rates with shockwave lithotripsy, and they studied these 3 variables, which we've already talked about a little bit. One of which is the infundibular pelvic angle, and that is the inner angle that is created by the transection of the 2 lines that we see here in the picture. The infundibular axis as well as the ureteropelvic axis. And obviously, as we all know, the broader that angle, theoretically, the easier it would be for resultant pieces to pass. They also looked at infundibular length and width, as we've talked about previously, but they reported that in this series, with stones averaging about 1.3 centimeters, that they approached almost 100% clearance when all 3 of these variables were favorable. Some other characteristics that we consider beneficial for ureteroscopy would be if a patient was morbidly obese or they had a bleeding disorder or complex intrarenal anatomy. These may be reasons that would preclude use of PCNL. The last one would just be, we see plenty of patients that have stones that are resistant to shockwave lithotripsy, as was touched upon previously, depending on their composition and their Hounsfield units. So these are all situations where ureteroscopy could be very helpful. Currently, we have the tools to make the difference. There's been rapid improvements in ureteroscope design that help us to reach the lower pole with relative ease. We have nitinol baskets and graspers that help us displace stones from lower pole positions to other more favorable anatomic positions. And we have lithotrites available that help us break stones down into very small pieces. This is just a picture that shows that, with today's flexible ureteroscopes, we can get into even the most dependent lower poles. We use the holmium laser as our lithotrite. It's an excellent lithotrite. It fragments all stone compositions. The stones can be hard. As long as you can touch the laser fiber to the stone, it'll break. It also has an excellent safety profile. This is an old study, almost 15 years old, that demonstrates that the holmium laser produces the smallest resultant fragments of all of the ureteroscopic lithotrites that are available, including EHL, mechanical lithotriptors, and pulse dye laser. They actually used sequentially smaller geological brass sieves to measure these resultant pieces, and most of the pieces that would get produced by a holmium laser are about 1 millimeter or less. We note that with a 200 micron laser fiber, we don't lose much in the way of deflection of our ureteroscope, so that if we had to treat a stone in situ, we could do it without losing too much deflection. We lose a little bit more with a 365 micron laser fiber, as you can see here. We should always consider displacing a lower pole or a lower caliceal stone to a different location if possible. It will help your stone-free rates be better, and it's going to be better for the health of your ureteroscope. Too many times as we try to treat stones in situ in the lower pole, as we deflect our scopes, we'll break those deflection cables if we're in that lower pole for too long of a time. At our institution, we make use of, this is a dimension basket, it's a barred product, but we like it because it actually articulates, as you can see. And with the use of a handpiece, we can shift that basket to different configurations, which will allow us to grasp a stone, but then also to be able to release it with relative ease. This comes as small as 2.4 French, and I know that there's other companies that make baskets and graspers that are 1.9 French, whatever it takes for us to be able to grasp a lower pole stone. And essentially, I'll leave you with this. This is a study, again, that was out of the University of Michigan almost a little bit more than 10 years ago. But what they demonstrated was that if you could displace a stone from a lower pole position to a more favorable calyx, that you can achieve higher stone-free rates, especially if the stone was greater than 1 centimeter. They demonstrated 100% stone-free rates with displaced calculi versus 29% for stones measuring between 1 to 2 centimeters. So by all means, if we can move it and then treat it, that's obviously the way to go with ureteroscopy.
Thank you very much, Scott. Any questions from audience?
Thank you for your talk. One question that came into my mind when you discussed the lower pole anatomy, and it also points out to previous talks, is that if I think about it, we used to do IVPs, which is an excellent tool in my mind, and most of those studies are based on IVPs, and IVPs are not commonly done today, and we don't routinely do CTUs on a patient unless there is a specific indication. So I guess most people would use the non-contrast CT as their tool and an X-ray. So I wonder what's the role of discussing the lower pole anatomy currently when, frankly, when you consider a patient for shockwave lithotripsy or when you discuss the different treatment options, these data is not in your hands today.
Yeah, excellent point. And that's a lot of the reason why I presented this, because I feel that this is a lost art. And I agree with you that IVPs aren't readily available, and at least in the United States, the radiologists really hate to do them nowadays. But I don't think that you can ignore that lower pole anatomy. If you do enough ureteroscopy as an endourologist, you're going to hate the cases that have that very acute infundibular pelvic angle and those very long lower pole calices, which are very thin. You know, this was apparent to me just after doing a lot of cases. I understand what you mean, that we don't have the IVPs anymore. We can't pull out the protractors and make the angles and do the measurements. I agree with that. I still do my best, though, to take a look, if I have a non-contrast CT scan, at a coronal view and at least get an idea, a broad idea of what things look like. And if you don't have a CT scan, or all you have is an ultrasound or a KUB X-ray, obviously you're right, it's going to be harder to make that judgment call. But I think that it's a lost art, and I believe that there's a lot to that lower pole anatomy that's useful to know.
By the way, at least in my hospital, I managed to persuade the X-ray guys to keep the IVP as an option, because I think it's a valuable option.
It's not the only hospital that still performs IVP. In our hospital also, in certain cases. Few remarks. First of all, your last study. It's hard to speak about 100% stone-free rate based on KUB.
Right, and that was only 7 patients. I agree.
Okay. Second, regarding lower pole anatomy, I don't know whether you remember, there are 7 studies that are claiming that there is correlation to stone-free rate and lower pole anatomy, and there are 6 studies, similar number of patients, similar size of stones, that are claiming that there is definitive no correlation between lower pole anatomy, bad lower pole anatomy, and stone-free rate. So I don't think that we can really say that lower pole anatomy influences lower stone-free rate. I agree with you, it makes ureteroscopy very hard, but not clearance of the stones. It's not from the literature. So in my view, only the very extreme bad lower pole anatomy really influences stone-free rate.
Just a comment on the ureteroscopy. If I had a patient with a lower pole stone, my first choice would be a shockwave lithotripsy. If I didn't think that I completely fragmented the stone, I think I would just retreat him with a second treatment rather than consider ureteroscopy. I think a patient, given the options, whether he'd rather have a second treatment versus a ureteroscopy and a stent, would much rather choose just a second treatment.
Well, this always does come down to patient choice and selection, and you have to have a discussion with the patient with regard to, the comorbidities that go along with each of the procedures. I agree. I don't think two shock waves is not unreasonable, to try to clear a lower pole stone burden. But I see plenty of patients who've had 2, 3, or even more that finally come to see us, and they're not always symptomatic. They just want the stone fragments removed. I just think, you got a good point, and that's what I put up in that first slide with that prospective study, was that there was obviously more quality of life, more preferable quality of life with shockwave lithotripsy with regard to mostly just because there were no stents placed. But I think it could go either way. I just think it's a patient selection matter, and they have to obviously take part in the discussion.
The last question, please.
Yeah. Well, I would say as a comment, as I see it's very convincing doing a shockwave lithotripsy. The patient doesn't understand exactly. He prefers the non-invasive. That's for sure. But he doesn't understand, maybe he doesn't get the real outcome of what happens after ESWL. So the patient thinks, well, it becomes powder, and it is not. So then he has the Steinstrasse, the obstruction. He comes into the emergency room. Well, we do the procedure, and then we forget the patient. Somebody else takes care. These days, having the small scopes, the flexible ones, the laser available, expeditiously you are there in the upper tract. You go easily to the stone. Usually, we just mix, I think, talking about PCNL, PCNL has the indication for large stones, complex stones. Now we started to mix with small stones in the lower calyx. Once you have a 1.5 centimeter stone in the lower calyx, easily you can resolve it with, in one session, doing a rhetoric approach. Having the laser, you leave a stent for 2, 3, 5 days with a string. You open the ureter for small fragments, and they've been delivered easily with no obstruction. So why not to do a 98% success a procedure in one session, then coming back for 1 or 2 or 3 sessions? It's for sure the patient always prefers the non-invasive. But you have to tell him and exactly to explain him that ESWL, it's not as good as this rhetoric approach. And that's evidence. That's one great evidence, and I think we know all the literature regarding this.
That's an excellent point. And I think one of the things that I've seen over time in patients who've had shockwave lithotripsy is that they get very dismayed when the stones don't clear within a few days. They can't understand why a few weeks after the shockwave lithotripsy they're still passing pieces. And so when I counsel patients on shockwave lithotripsy, I always bring that up. And after I tell them that, a lot of them would rather have ureteroscopy and just be done with it, to your point. And so, you know, especially with the other gentleman who brought up the second shockwave treatment, I mean, if it's a lower pole position and those fragments aren't coming down, you know, maybe we have to ask ourselves, why are we even treating that stone?
What would be your preferred instrument to get to the lower pole? You prefer flexible ureteroscope? And going back to the anatomical issue, I do not believe that we need a detailed anatomy of the kidney and the collecting system before proceeding with an endourological procedure. It is important when planning a shockwave lithotripsy to get if there is an adverse factor for successing in shockwave lithotripsy. Usually, what I'm doing today is getting informed consent for the patient for both a retrograde procedure and a percutaneous procedure, and perform the procedure in a supine position. So we can try to perform a RIRS. You can perform on the table a retrograde pyelography to get the real anatomy, and if you are not able to complete the procedure in this fashion, you can proceed with a percutaneous procedure.
Okay, so I'll address the first question. What do we use to reach the lower pole? At our institution, we typically use the Stort's FlexX. We use the FlexX2. We're in the process of trying to get a few of the digital models, the FlexXC. But those two pictures that I showed before entering the lower pole were with the Stort's flexible ureteroscope. But most modern ureteroscopes these days will be able to do that. With regard to the comment about being set up to do both procedures, that's a very reasonable way to go, but there would be a few things that I would think of. First off would be, in men especially, I find it somewhat, it's possible, but it's a little painful to perform ureteroscopy in a retrograde fashion when they're prone. It can be done, I agree, but there's, well, that's fine, and I know, you know, especially in Europe and in other places, the supine approach to a PCNL is very viable, and I've seen that. We haven't really adopted that to a large degree in the United States, but I've read the literature, and that definitely is a way to go, and that's fine. You just have to be a few things. You have to be prepared for it, and you have to have the the skill to approach things percutaneously in that regard. But it's a good point.
Thank you very much, Scott.